today I will be presenting regarding sepsis and rational use of antibiotic in surgery. So, what is definitions of sepsis? So, sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. So, in patients with sepsis, they will have 10% of mortality risk. So, the next definition is septic shock. Septic shock is when the patient having sepsis, despite adequate volume resuscitation, the patient still need vasopressor to maintain the mean arterial pressure 65 or more, or the measured serum lactate is more than 2. So in patients who have septic shock, they will have 40% of mortality risk. So this is the old definition. Now we did not use this definition anymore. The old definition of sepsis. So why the change in practice? Before this, we use SIRS, which is Systemic Inflammatory Response Syndrome. Why we now we use SOFA score? Why we change? Because SIRS is not an ideal marker for sepsis. SIRS criteria also present in many hospitalized patients, including those who never develop infection and never incur adverse outcome. So SOFA score used to predict in-hospital mortality is superior to the SIRS criteria. That's why we changed the practice from SIRS to SOFA score in sepsis. Yes, next is the clinical criteria for diagnosis of sepsis. So, organ dysfunction. What is definition of organ dysfunction? It is defined as increase in the SOFA score 2 points or more. So what is SOFA score? It is a sequential organ failure assessment. Like I said before, in patients who have sepsis or organ infection, mortality rate is 10%. Other than SOFA score, we also have Q-SOFA, which is quick SOFA score. This is the simplified version. We can use this during the bedside if we suspected infection in patients who are likely to have a poor outcomes. So, how to remember easily Q-SOFA? We have 3 criteria. The component we can easily remember by HAT. HAT. H is hypotension, which is systolic blood pressure is less than 100. The next one is A. A is altered mental status, where the GCS is less than 15. The next one is T, where the patient having tachypnea, where the respiratory rate is 22 breaths per minute or more. So what is the advantage of using the Q-SOFA at the bedside? We don't need to have any lab tests. It's an early initiation. We can start early initiation or escalation of therapy. Then we can refer to critical care center early. Then able to decide frequency of monitoring and prompt consideration of possible infection in patient not previously recognized as infection. So as we can see here, this is the table of the full SOFA score. We can see here, the SOFA score cover respiratory system, then coagulation profile, liver, cardiovascular, the brain, central nervous system, and then the renal, and also urine output. So the first one is respiratory system. The SOFA score, we need to measure the concentration of oxygen and FiO2 ratio. So that's why we need to take ABG in patient who suspected sepsis lah. So the score 0 when the oxygen saturation oxygen pressure is and FiO2 ratio is 400 or more. 0 score. When 1 score is less than 400, 2 less than 300, 3 less than 200, and 4 3 less than 200 with respiratory support, 4 less than 100 with respiratory support. Next one is coagulation, where we take the platelet. So if a 0 score, the platelet is normal lah, 150 or more. If 1 is less than 150, 2 less than 100, 3 less than 50, 4 is when platelet is less than 20. The next one, we look at the liver. So we look at the bilirubin. It score 0 when the bilirubin is less than 1.2. 1 is 1.2 to 1.9. Into when the bilirubin is 2 to 5.9, 3, 6 to 11.9, 4 is when the bilirubin is more than 12. The next one is cardiovascular. This one we look at the mean arterial pressure at the blood pressure machine. The score 0 is when mean arterial pressure is 70 or more. In 1 is when the MAP is less than 70. The 2 when we need to use dopamine less than 5 or dobutamine to support the MAP. 3 when we need to use dopamine 5 to 15 or epinephrine 0.1 or less, or no epinephrine 0.1 or less. In 4 we need to use dopamine more than 15 or epinephrine more than 0.1 or no epinephrine more than 0.1 to support the MAP. The next one is central nervous system, where we need to calculate the GCS score. It score 0, full GCS 50. 1 when the GCS is 13 to 14. 2 GCS 10 to 12. 3 6.9. 4 when the GCS is less than 6. So the next system is renal, where we calculate the creatinine and also urine output. So for creatinine 110, the score is 0. When the creatinine is 110 to 170, score is 1. 171 to 299 is score 2. Then 300 to 440. Then more than 440 creatinine is a score of 4. Then the next one is urine output. Urine output, when the patient have urine output less than 500 ml per day, we calculate as score 3. And if less than 200 ml per day, we calculate as score 4. So this is the Q-SOFA score that I told before. So we have 3 components: HAT. H is hypotension, A altered mental status, T is tachypnea. So when we calculate the Q-SOFA score, when the patient have 0 or 1 points, the patient we not high risk patient for sepsis. So we continue the management as appropriate. But if the patient have 2 or 3 points in Q-SOFA score, we consider this patient is high risk of poor outcome. So we need to assess for evidence of organ dysfunction, where we need to use the full SOFA score. So the pathophysiology of sepsis. Okay, so firstly, the patient will have local infection by the pathogen, and then the systemic host immune response to infection happen. Then this will increase the capillary permeability and peripheral vasodilation that will lead to distributive shock that lead to reduced central circulation. When reduced central circulation happen, this will reduce the tissue perfusion at our vital organ, which we have 4: brain, heart, kidney and lungs. and this will lead to death if not resuscitated or not started antimicrobial agent and escalate accordingly. So this is the table for management or how we want to identify sepsis and sepsis shock using the Q-SOFA and SOFA score. So the first, when we suspected patient having infection, we need to do Q-SOFA score at the bedside. So if Q-SOFA have 2 points or more, we need to assess for evidence of organ dysfunction. Then we need to use the SOFA score. If SOFA score is more than 2, we consider this patient having sepsis. And then we need to start adequate fluid resusc. If the patient with the adequate fluid resusc, but the patient still need vasopressor to maintain the MAP 65 or more and the serum lactate more than 2, we consider this patient having septic shock. If the Q-SOFA score is 1 or 0, but the sepsis still suspected, we need to assess for evidence of organ dysfunction also. Then if a Q-SOFA score less than 2, and then the sepsis not suspected, monitor clinical condition and re-evaluate for possible sepsis if clinically indicated. Okay, so the sepsis, we have hour 1 bundle where the 1 hour duration during initial of sepsis, 1 hour during the sepsis is very important, the first 1 hour of sepsis. So what we need to do during the first 1 hour, we need to measure lactate level and obtain blood culture before administering antibiotic. After we take the blood culture, then we administer the broad spectrum antibiotic. And in sepsis also, in septic shock, we need to begin rapid administration of 3 ml per kilo crystalloid. This is a fluid for hypotension for a patient having hypotension or lactate 4 or more. Then apply vasopressor if hypotensive during or after fluid resusc to maintain a MAP 65 or more. And remeasure lactate if initial lactate elevated more than 2. So in sepsis, we need to act quickly upon sepsis and septic shock recognition, and we need to minimize time treatment as sepsis and septic shock are considered as medical emergency. Then we need to monitor closely for response to our intervention. Then communicate sepsis status in hands-off. This is the simplified diagram for the first 1 hour sepsis management, the initial resuscitation in sepsis. So we can easily remember by take 3, give 3. So what we need to take from the patient is lactate. The first, we need to take lactate, blood culture prior to giving antibiotics, and monitor urine output. We need to make sure the patient having urine output more than 0.5 cc per kilo per hour. Then what we need to give to patient is oxygen, high flow mask, 15 liter per minute if indicated, and crystalloid. If sepsis, we give 10 to 20 cc per kilo Hartmann. And if a patient having sepsis-induced hypoperfusion or septic shock, we need to give 30 cc per kilo Hartmann, and then give antibiotic, broad spectrum antibiotics. And then after all these 6, we need to reassess the patient. So what we need to reassess the patient, the first one is urine output hourly, MAP, mean arterial pressure, make sure is 65 or more. If not, if less than 65, start vasopressor. If the mean arterial pressure is still less than 65 after we give the fluid bolus, fluid resusc, 30 cc per kilo. Then monitor the lactate and the VBG, repeat post-fluid resusc. Repeated lactate and VBG post-fluid resusc. We aim to correct metabolic acidosis and reduce lactates to less than 2. In special group, like in patient who having heart failure or end-stage renal failure, we need the patient need to have cardiac output monitoring or CVL insertion. So, antimicrobial therapy in sepsis should be guided by the local antimicrobial stewardship team. Then appropriate routine microbioculture, including blood culture, must be obtained before starting antimicrobial therapy. Intravenous antimicrobial therapy should be initiated within 1 hour of recognition of sepsis. The escalation of the therapy to the narrowest effective agent should be implemented when the likely pathogen identified. Means we have the result of the sensitivity from the blood culture sample. Then duration of antibiotic usually 5 to 10 days. In uncomplicated Staph aureus bacteremia, at least 14 days of therapy. In complicated bacteremia, at least 6 weeks of therapy. So the next one, we move to the rational use of antibiotics in surgery. We have 3 group. The first one we use for prophylaxis. The prophylaxis is the antibiotic used to prevent infection. The next one is antibiotic for empirical therapy, where we use broad-spectrum antibiotic to treat clinically suspected infection. The third one is targeted therapy, where we use specific antibiotic to treat bacteriology confirmed infection with culture sensitivity. So in surgery, we need to know the classification of wound. The first wound is clean wound, where the surgery involves uninfected operative wound without inflammation, and also respiratory, alimentary, genital or uninfected urinary tract are not entered. The next one is clean/contaminated, where the operative wounds in the respiratory, alimentary, genital or uninfected urinary tracts are electively entered without unusual contamination. The next one is contaminated wound, where the wound is open, fresh, accidental wounds, operation with major breaks in sterile technique or gross spillage from the GI tract, and incision in which acute non-purulent inflammation is encountered. The next one is dirty wound, where all traumatic wound with retained revitalized tissue or dead tissue, or those that involve existing clinical infection or perforated viscera. So the common surgical pathogens, if clean procedure, the most common pathogen is skin flora like Staph aureus, Coagulation negative Staph, Staph epidermidis. If clean contaminated procedure, we have gram-negative rot like Klebsiella pneumoniae, Pseudomonas, E. coli. Then is Enterococcus, anaerobe and skin flora. So surgical antibiotic prophylaxis, we need to administer antibiotic when indicated within 60 minutes or 1 hour before skin incision. So what is the indication of antibiotic prophylaxis? So the indication is for clean contaminated and contaminated procedure, and certain clean procedure with expected contamination. So what is the goal of antibiotic prophylaxis? It is to prevent the surgical site infection and related morbidity and mortality, and also reduce the duration and cost of care, produce no adverse effect, and minimize adverse consequence to the microbial flora. So next we will look at the common surgical procedure and the antibiotic of choice. So in general surgery procedure, usually all procedure we will give cefazolid 2 gram. Example we can see here, like appendectomy. If uncomplicated, usually we give cefazolin and flagyl, like we can see in the ward, and also colorectal case also. Then also we can give unacin also, unacin 3 gram. If the surgery involves a small intestine, if it is a non-obstructed case, we can give cefazolin. If obstructed case in small intestine, we need to add flagyl. Then hernia repair also we use cefazolin. Okay, this is the preferred antibiotic treatment prophylaxis. And another general surgery, all the breast surgery, the same, we use cefazolin. You can read the alternative here. You have augmentin and unacin. So this is the for breast surgery. Okay, the next one is uro. In uro, so example in transrectal ultrasound and prostate biopsy, because this surgery involve common organism like E. coli, Klebsiella, Proteus, Enterococcus, and Pseudomonas. So the prophylactic antibiotic is oral ciprofloxacin and plus minus gentamicin. Then in cystoscopy or urodynamic study, antibiotic not recommended. Another procedure is retrograde pyelogram or ureteric stenting. Usually we give only oral cefuroxime. Then endourology, endourological surgery, PCNF, percutaneous nephrolithotomy, ureteroscopy, retrograde intrarenal surgery, and ureteral resection of prostate. We usually use augmentin or unacin. So other surgeries like clean operation like orchidectomy, orchidopexy, varicose, selectomy, deroughing of renal cysts, antibiotic not required. In clean contaminated with opening of urinary tract, example like nephrectomy, prostatectomy, or open stone surgery, we need to give prophylaxis, augmentin or unacin. Another clean contaminated surgery with use of bowel segment like cystectomy with urinary diversion or cystoplasty, usually we give cefoperazone and flagyl. And the next is implant of prosthetic device, example insertion of benign prosthesis or artificial urinary sphincter or artificial slings. Usually we need to give IV cefuroxime, TDS 1.5 gram for 1 week. Laparoscopic surgery is same as the open surgery, and depending on type of procedure performed, whether clean or clean contaminated. So why is important for surgical site infection? We need to know regarding the prophylaxis, because surgical site infection is the second most common hospital acquired infection, where it covers 25.4% of all hospital acquired infection in Malaysia. So surgical site infection usually occurs within 30 days after surgical procedure if no implant is left in place, or within 1 year where there is a prosthetic implant. So surgical site infection occur mostly in emergency op compared to elective op. So as you can see in this table, we can see infection rate with prophylaxis versus infection rate without prophylaxis. In clean surgery, the infection rate with antibiotic prophylaxis only 1 to 2%. Without prophylaxis is same. But in clean contaminated, the infection rate with prophylaxis 3, but without antibiotic prophylaxis is 6 to 9%. In contaminated procedure, the infection rate with prophylaxis is 6%, where the infection rate without prophylaxis is high, which is 13 to 20%. In dirty, where pus or perforation happen or incision through an abscess, with prophylaxis, the SSI happen only 7%. Without prophylaxis, 40%. So there is two factors affecting rate of SSI. We can divide into two. The first one is surgical factors and patient factors. For surgical factors, example, basic infection control strategies, surgeon techniques, duration of the procedure, hospital and environment factors, and pre-op preparation. Patient factors including extreme of age, nutritional status, obesity, diabetes mellitus, patient having coexistent infection, altered immune response, patient taking steroid therapy, and length of pre-op hospitalization. The next one is empirical therapy. Empirical therapy we use when there is a risk of surgical infection is high and significant contamination during surgery has occurred, where considerable spillage of colon content. Example, we also use empirical therapy in critically ill patient with severe sepsis or septic shock. Empirical therapy usually we give only for short course for 3 to 5 days. Example is oral ciprofloxacin or azithromycin. So de-escalation therapy. De-escalation therapy refer to initial short-term broad-spectrum antibiotic coverage in severely ill patient, which are followed by change to more narrowed focus regimen that are driven by culture and other laboratory results once there are signs of clinical stability. This de-escalation therapy also have advantage of limiting emergence of resistant organism, pertinent in dealing with life-threatening condition, especially infection in clinical care patients, immunocompromised patient, and patient with risk of hospital-acquired infection. So, in conclusion, antibiotic alone are unable to prevent surgical site infection. Strategies to prevent surgical site infection should always include attention to infection control and prevention strategies. Antibiotic prophylaxis should be administered for operative procedures that have high rate of post-op surgical site infection or when foreign material are implanted. Antibiotic given as prophylaxis should be effective against the aerobic and anaerobic pathogens most likely to contaminate the surgical site. Example, gram-positive skin commensal or normal flora colonizing the incised mucosa. Antibiotic prophylaxis should be administered within 2 hours prior to the incision. However, administration of the first dose of antibiotic beginning within 30 to 60 minutes before surgical incision is recommended for most antibiotic to ensure adequate serum and tissue concentration during the period of potential contamination. A single dose is generally sufficient. Additional antibiotic dose should be administered intraoperatively for procedure longer than 2 to 4 hours or with associated significant blood loss more than 1.5 liter. There is no evidence to support the use of post-op antibiotic prophylaxis. Each institution is encouraged to develop guidelines for the proper surgical prophylaxis. That's all from my side.